So if you break your arm, an X-ray gives you a really clean, binary answer. The doctor just points to a jagged white line on a glowing screen, and there it is. It's broken.
Right. It's undeniable. You can see the problem right there.
Exactly. But if you are experiencing this agonizing burning sensation every single time you urinate, the diagnostic landscape is just painfully murky.
Oh, absolutely. It's incredibly frustrating for people.
Yeah. So today we are focusing on a highly specific and often invisible agony, which is an active flare-up of lichen sclerosus, or LS. And we're going to look at exactly why your body turns a basic daily function into a complete nightmare.
It really is a symptom that just silently dominates the daily lives of those who experience it. I mean, people often suffer for years, right? Because they just assume they're dealing with recurrent infections.
Like endless UTIs.
Yeah, exactly. Because the underlying mechanism of the pain is just so rarely explained to them with the necessary mechanical clarity.
Well, to provide that clarity today, we brought a stack of incredibly rigorous sources to the table. We are pulling directly from the clinical guidelines of the British Association of Dermatologists and the NHS, some really comprehensive pathology breakdowns from the Mayo Clinic, and the highly practical frontline FAQs developed by the Women's Health Clinic and the Lichen Sclerosis Support Network.
Yeah, the literature gives us a really full spectrum view here. We can basically trace the issue from the cellular pathology of the disease, deep within the skin, all the way to the daily tactical management of the symptoms right in a patient's bathroom.
Right. And our mission for this deep dive today is to unpack exactly why this burning happens mechanically, like how the physical anatomy of the body actually changes to trap irritants, and what the medical consensus says about breaking this painful cycle at the root.
Because understanding the mechanics of the pain is really the first step in moving from, a state of fear to a state of strategic management.
Definitely. And I want to speak directly to you, the listener, right now. If you or a loved one are experiencing this, the isolation can feel entirely overwhelming. But this deep dive is designed to strip away the confusion and hand you clear, science-backed leverage over the condition.
That's the goal. Let's get into the mechanics.
Right. So when I was reading the Mayo Clinic source, the physical description of the skin during an LS flare-up was honestly startling. They described it as looking like crumpled cigarette paper.
Yeah, that's a very common clinical description.
Which is wild.
Yeah.
How does an immune response strip the skin of its natural structure to the point where it looks like crumpled paper?
Well, we have to look at the basal layer of the skin. So lichen sclerosus is a chronic inflammatory autoimmune condition.
Okay.
And what happens is the immune system's T cells mistakenly identify the skin cells in the genital and perianal areas as a threat.
Like it thinks its own skin is an invader.
Exactly. So these immune cells infiltrate the dermis and they just begin breaking down the structural matrix. Specifically, they're destroying the collagen and elastin that usually give healthy skin its stretch and resilience.
So it basically stops acting like a dynamic organ and becomes completely rigid.
Right. And healthy tissue in that area, it's built to handle constant movement, right? Friction, moisture. But as the LS skin loses that elasticity, everyday movements like walking, sitting, or even just normal stretching would naturally lead to structural failure.
Because it can't stretch anymore.
Precisely. The skin simply splits open. We call them micro tears or fissures.
Okay, so you have these tiny open cuts all over.
Yeah, and healthy skin usually has a tough outer layer at the epidermis, which acts as a shield for the highly sensitive nerve endings residing in the deeper dermal layers.
Right, the armor.
But the chronic inflammation of LS basically eradicates that shield.
Wow, so those nerve endings are entirely exposed.
Completely exposed.
And then, several times a day, urine flows directly over them. Let's talk about the chemistry of that moment, actually.
Yeah.
What exactly is happening when urine hits those fissures?
Well, urine is essentially a liquid byproduct of the body's filtration system. So it contains urea, uric acid, ammonia, and various dietary salts.
Which doesn't sound great on an open wound.
It isn't. And depending on a person's hydration levels, that fluid can be surprisingly acidic. So when you have concentrated uric acid and salts washing over exposed, inflamed dermal nerve endings, it creates a severe chemical shock.
So because the skin is paper thin and cracked, passing slightly acidic urine over it is essentially like squeezing lemon juice onto a paper cut.
Yeah.
But in the absolute most sensitive part of your body.
That is exactly it. It's a perfect analogy. The chemical shock is intense.
Which really explains why so many patients you read about in the Women's Health Clinic literature end up delaying proper treatment. Because the burning feels so intensely chemical, they just logically assume, oh, I must have a urinary tract infection, or maybe it's thrush.
Right, they go to the doctor for antibiotics or antifungal creams.
But antibiotics won't do a thing here.
No, nothing at all. Because the pain isn't an infection inside the urethra, it is a strictly mechanical problem. It's a compromised skin barrier acting as an open wound, and it's just reacting to an acid
A
wash.
daily acid wash.
Exactly. And, this distinction really changes the entire approach to patient care. If we understand the pain as raw physical contact between an irritant and an unshielded nerve, the focus shifts entirely to barrier protection and structural repair.
Instead of just blindly throwing antimicrobial treatments at it.
Right. It's about protecting the wound.
So we have this constant cycle of tearing. But the sources point out that the body doesn't just leave a tear open, right? It constantly attempts to heal it.
It tries, yes.
And that healing process, the scarring, actually changes the physical plumbing of the area.
Yeah, this is where things get even more complicated. The medical term is sclerosus, which refers to the stiffening and scarring of tissue.
Hence the name lichen sclerosus.
Exactly. When the body repeatedly tries to heal these inflammatory microtears, fibroblasts lay down disorganized, stiff collagen.
Basically like patch jobs.
Yeah, poor quality patch jobs.
Yeah.
And over time, this fundamentally alters the genital architecture. This architectural shift actually traps the urine, which creates this devastating feedback loop.
I saw that in the Mayo Clinic and the Stat Pearls research. They highlight how this manifests in men, referring to it as BXO or Balanitis serotica obliterans.
Right. So when the male anatomy is targeted, the scarring primarily attacks the foreskin and the glands. The progressive fibrosis causes the foreskin to tighten a condition known as phimosis, which eventually makes it impossible to retract.
Oh, wow.
And simultaneously, the scarring can cause medial stenosis, which is a narrowing of the actual urethral opening.
So instead of a clean, forceful stream directed away from the body, a narrowed opening would just cause the urine to spray or dribble.
Exactly.
And with a tightened foreskin that won't retract, the urine is just basically getting caught inside the anatomy.
Yeah, the literature refers to this as microincontinence. The acidic urine pools under the tightened foreskin, just resting continuously against the fragile, already inflamed skin of the glands.
That sounds incredibly painful. And the anatomical changes in women described in the text sound just as drastic in terms of altering the natural flow of fluids.
They really are. In the female anatomy, chronic LS inflammation causes the vulvar tissue to actually resorb.
Resort, like it just disappears.
Essentially, yeah. The labia minora, the inner lips, can flatten out and disappear entirely into the surrounding tissue. And the skin of the clitoral hood often fuses together, which can effectively bury the clitoris beneath a thick layer of scar tissue.
So the natural funnels and channels that normally direct urine safely downward and away from the body they're essentially erased.
Erased and replaced by irregular folds and adhesions.
New pockets.
Right. So when a woman with advanced LS urinates, the fluid catches in these newly formed pockets and blind alleys. The urine pools against the very fissures we discussed earlier, rather than flowing away cleanly.
Wait, if the urine gets trapped against the skin because of these anatomical changes, does that trapped urine actually accelerate the disease itself?
Oh, it absolutely does. It
Yeah.
acts as a continuous localized stressor. Lichen sclerosus is driven by a hyperreactive immune system, right?
Right.
So when you introduce the chemical irritation of trapped uric acid to an area that is already teeming with inflammatory cells, it signals to the body that the area is under severe attack.
It's like throwing gasoline on the fire.
Literally. The immune system responds by flooding the tissue with even more T cells and inflammatory cytokines.
It's a completely self-feeding fire. Yeah. The inflammation causes the tearing and the scarring, then the scarring creates the pockets that trap the acid, and the trapped acid triggers more inflammation.
It's a vicious cycle.
So we have to figure out how to break this cycle mechanically on a daily basis.
We do. And the tactical defense outlined in the literature revolves around a really simple mandate. Prevent the acid from making contact with the compromised dermal layers.
Right, which brings us to the Lichen Sclerosus Support Network and the NHS guidelines. They lean heavily on something called the peri-bottle hack.
Yes, very practical advice.
Yeah, using a peri-bottle, or like an upside-down travel bidet, to spray a continuous stream of warm water over the area while urinating. I want to look at the pH dynamics of this.
Well, as we established, urine acidity fluctuates. If a patient is even slightly dehydrated, The concentration of uric acid spikes, making the chemical shock to those open fissures much, much more severe.
The lemon juice gets more concentrated.
Exactly. So squirting warm water over the area during urination does two things simultaneously. First, it mechanically flushes the fluid out of those anatomical pockets we just talked about.
So it can't pool.
Right. And second, it instantly dilutes the pH of the urine in real time.
So you are neutralizing the acid before it can settle into the dermal layers.
Precisely.
But, water alone isn't going to protect someone if they are away from home or if the microtears are particularly deep.
No, they need something more robust.
Right, and the Women's Health Clinic FAQ specifically instructs patients to use a barrier cream before urinating. But they emphasize plain, unscented petroleum jelly, Vaseline.
Yes. Plain Vaseline.
Which feels a little counterintuitive today. I mean, in an era of incredibly advanced, multi-ingredient, intimate skincare, why are they so strictly against using soothing botanicals like, I don't know, aloe or chamomile or lavender?
That's a great question. The concept of soothing changes entirely when the skin barrier is broken.
Okay, how so?
Well, complex creams contain dozens of distinct botanical compounds and preservatives, right?
Right.
And to an intact epidermis, they're perfectly harmless. But when applied directly to exposed dermal tissue and inflamed immune cells, these compounds are frequently registered as foreign invaders or allergens.
Oh, wow. So introducing complex plant extracts to an active autoimmune flare-up could actually trigger an allergic contact dermatitis on top of the lichen sclerosus.
Exactly. It's the absolute last thing you want to do.
Yeah.
The clinical guidelines steer patients toward petroleum jelly precisely because it is biologically inert.
Meaning the body just ignores it.
Completely. The body does not recognize it, nor does it attempt to interact with it. Furthermore, it's highly occlusive and hydrophobic.
It repels water. So plain petroleum jelly isn't trying to heal the skin at all. It's basically acting like a layer of wax on a car. The acidic urine just beads up and rolls off without ever penetrating the paint.
That captures the mechanics perfectly. It is a waterproof shield, nothing more, nothing less.
And the physical act of managing that area afterward is just as critical, right?
Mm-hmm.
The sources universally stress the importance of dabbing the skin dry with soft tissue, never rubbing.
Never rub. Because mechanical friction on tissue that is already devoid of elasticity will simply create new microtears.
You'll just rip the skin again.
Exactly.
So diluting the acid with a peri bottle, applying the inert car wax shield of petroleum jelly, and dabbing to avoid friction. These are brilliant tactical defenses for symptom management.
They are essential for daily survival.
But reading through the British Association of Dermatologists guidelines, it is explicitly clear that barrier methods only address the symptoms.
Right.
To actually stop the skin from tearing, you have to shut down the cellular inflammation.
You cannot cure an autoimmune response with water and Vaseline.
Right.
The root cause is the localized immune attack degrading the structural matrix of the skin. You have to interrupt that specific biological process.
And across all the medical texts we reviewed, I mean, the NHS, the Mayo Clinic, the dermatological associations, the absolute gold standard for this is the use of ultra-potent topical corticosteroids, specifically a medication called clobetasol propionate.
Yes, clobetasol. And to understand why it's the gold standard, we really have to look at how it operates at a cellular level.
Okay, let's get into it.
So clobetasol propionate doesn't just sit on the surface. It penetrates the cell membranes in the dermal layers and binds to specific glucocorticoid receptors inside the cytoplasm.
Inside the cell itself.
Right. And once bound, it actively inhibits the synthesis of inflammatory proteins and cytokines.
So using the steroid is essentially like turning off a false fire alarm.
Basically, yes.
Because the immune system thinks there's a massive fire in the tissue, so it is tearing apart the house with water and axes to try and put it out. And the clobetasol shuts off the alarm, sending the immune cells away, so the fibroblasts can finally come back in and, rebuild the collagen walls.
Exactly. Once that inflammatory cytokine storm is halted, the tissue can exit the destructive phase and finally enter a reparative phase. The skin can actually slowly regain its normal thickness and elasticity.
Which is incredible. But this brings us to a massive paradox in the literature, and it's one that causes immense anxiety for patients.
The warning labels.
Yes. The instructions printed on the boxes of these ultra-potent steroids by the manufacturers literally contain a warning label that says, "Do not use on genital skin."
I know.
If a patient is suffering from a genital skin condition and reads that warning, their immediate instinct is going to be to throw the tube in the trash. Sounds terrifying.
It does. It is a massive systemic communication failure between regulatory agencies and clinical specialists.
How does that even happen?
Well, regulatory agencies require that warning label as a generic mandate to protect the general public. Because if someone were to use an ultra-potent steroid on healthy genital skin, say, to treat a simple fungal rash, the steroid would indeed degrade the healthy tissue matrix. It would cause severe thinning and localized damage.
But the difference here is that lichen sclerosus skin is already pathologically altered. The disease has already done the thinning.
Exactly. The British Association of Dermatologists and the NHS guidelines explicitly instruct LS patients to ignore that generic warning.
Ignore it completely.
Yes. In the context of lichen sclerosus, clobetasol propionate is the standard of care. It is literally the only evidence-based mechanism to halt the destruction of the tissue.
So it doesn't thin the skin further. It stops the disease that is causing the thinning in the first place. But the guidelines are very specific about the dosage, right? The texts emphasize using a tiny amount, about a pea-sized application, for the entire affected area. A standard 30-gram tube is supposed to last a patient roughly 3 months.
Yeah, you don't need much. The strategy is consistent long-term suppression of the localized immune response rather than just flooding the system all at once.
That's slow and steady.
Right. By maintaining that steady, low-dose cellular inhibition, you achieve the vital clinical outcomes. You stop the microtearing, which entirely eliminates the burning pain during urination.
Because there are no more open cuts.
Exactly. And you halt the progressive fibrosis, preventing the irreversible anatomical scarring and fusion.
And I noticed the Mayo Clinic research highlights that long-term compliant use of these topical steroids significantly reduces the lifetime risk of developing squamous cell carcinoma,
Yes, that's crucial.
which is a type of skin cancer that can arise in tissues subjected to chronic, unchecked LS inflammation.
Right, because chronic inflammation damages DNA over time. So it really is a comprehensive intervention. The tactical tools manage the daily reality, while the medical treatments rewrite the long-term prognosis.
So let's pull all of these mechanics together for the listener.
Good idea.
That agonizing burning sensation when you pee is fundamentally a mechanical problem. It is slightly acidic urine, whose pH fluctuates based on your hydration hitting exposed dermal nerve endings through fragile microtorn skin.
Yep.
And the body's attempt to heal those tears creates scar tissue that alters your anatomy, physically trapping the urine and accelerating the autoimmune fire.
A terrible feedback loop.
Right. So you defend against this daily by diluting the acid with a peri bottle and creating an inert, waterproof shield with plain petroleum jelly. But to actually rebuild the skin's elasticity and prevent permanent scarring, you have to use ultra-potent prescribed steroids to turn off the inflammatory alarm at a cellular level, trusting the clinical guidelines over the generic warning labels.
That sums it up perfectly. And, there is one final, really fascinating detail buried in the dermatological texts that sort of reframes how we look at this entire condition.
Oh, yeah.
Yeah, it's a phenomenon known as the Koebner response.
I saw that mentioned briefly in the pathology section. What is it exactly?
So the Koebner response occurs when mere physical friction on the skin, so chronic rubbing from tight clothing, the mechanical trauma of scratching, or even a minor surgical incision, somehow tricks the body into triggering a new autoimmune lichen sclerosus flare-up in that exact location.
Wait, really? Just from friction?
Yes. The body registers the mundane physical trauma, but instead of sending standard healing factors, it mounts a full-blown, inappropriate autoimmune attack.
Wow. It just completely overreacts.
It really does.
It makes you wonder how deeply our internal immune surveillance is listening to the physical friction of our daily lives, and what normal, everyday mechanical stressors it might be completely misinterpreting as an invading threat.
It's a profound medical mystery, for sure.
It really is something to mull over. Well, we want to thank you, the listener, for joining us on this deep dive. Keep questioning the mechanics of what your body is experiencing. Keep learning the science behind the symptoms. And, most importantly, bring these specific cellular insights to your next medical appointment. The diagnostic landscape might be murky, but the mechanics of healing are clear.